Okay, we're ready to start the scientific part of the program, and it's my great pleasure to introduce the first speaker. As you've seen from the program, there will be a lot on especially shoulder injuries, different aspects of it during the whole meeting, and we thought that one person who really knows a lot of injuries in the shoulder, especially rotator cuff and rotator cuff tears, is Professor Andrew Carr from Oxford University. He's an orthopedic surgeon and is a professor there, and has worked a lot with different aspects of it in relation to treatment, pathology, epidemiology. So we thought it would be a nice thing to let Andrew Carr start off and give the opening lecture here. So a warm welcome to you, and the floor is yours.
Thank you very much, Michael. Thank you for the invitation. It's a great pleasure to be here, and I hope in these next few minutes I can cover some things that interest some of you. It's a fairly mixed bag of topics I'm going to cover in the lecture. So I'm going to do a little review of some of the epidemiological work we've done using a general population cohort based in one of the suburbs of London. Then talk about some of the results of randomized controlled trials that I've run through Oxford. And then move on to work we've been doing in my group looking at mechanisms of disease using tissue biopsies, and particularly to address the question, is there or is there not inflammation in tendon disease? And then finally, to talk a bit about some of the work I've been doing developing nanofiber scaffolds to augment surgical repair of tendon. So that's just to give you can go to sleep now for a while if you want. That's just give you a feeling for what I'm going to talk about. So I think one of the important things for us at the moment in the disease area that we treat is to understand and appreciate the unbelievable explosion in work that's likely to be coming our way. And I don't know whether you've seen this really excellent piece of work published in The Lancet last year, looking not at disease as a cause of death or cause of premature death, but looking at disease as a cause of disability, and describing it not just in terms of the magnitude and severity of the disability, but the duration of the disability through your life, and creating a ranking or a scaling of what it is that causes people, particularly in developed societies, to live with disease for years. And what I think is important here is that musculoskeletal causes of years lived with disease are prominent. There are 5 of the top 15. And this is only going to get worse as societies age, as our communities develop in terms of their demographics. So there is a huge need to address this problem if we can, to push out healthy years for longer, to minimize the impact. It's not therefore going to be a question of when you die and what you die from, but how did you suffer before you died? And what we need to try and do is minimize that. The aspect that I've been focusing on for a good 10 plus years now is diseases of the shoulder, and particularly diseases of the shoulder that cause pain for whatever reason, be they sports injury related or age related. It gets commoner as we get older. Most people will settle with relatively simple strategies, but some persist, and some persist for quite a long time. And what has become apparent is that quite a common cause, or the commonest cause of shoulder pain, is disease of the tendons of the rotator cuff, in particular the supraspinatus, but also other tendons around the shoulder. And it's that disease area that I've been looking at in my research group in Oxford. And one aspect, I think, is to think, well, what's special about the human shoulder? And again, there's a nice piece of work published in Nature a couple of years ago looking at the evolution of the human shoulder, a nice biomechanical study. And what is interesting about the human shoulder is its morphology is different to other animals, obviously to quadrupeds, but also to other primates. And what we have evolved is an extraordinary ability to throw. And throwing throwing speeds generated by the human shoulder are way in excess, 5 times greater than the throwing speeds that can be generated by any other primate. And that energy required to throw comes from both stored energy and also energy generated by muscles. The ability to throw probably enabled us to feed our brains, so enabled us to evolve, because without the ability to bring down woolly mammoths or whatever else with spears by both running after them and also throwing things at them, we wouldn't have been able to get enough food to feed the brains, which then allowed us to evolve into the species we are now. So man's throwing ability is clearly important in the evolutionary terms. One of the consequences of throwing and this adaptation is probably that we have developed a propensity to disease of these tendon structures around the shoulder. And here you see some both schematics and operative pictures and imaging pictures of, generally speaking, what's regarded as the progression from a tendinopathy to small and then increasingly larger tears of the rotator cuff, within some people, actually a relatively small proportion of people develop a kinematic mismatch so that you get a problem of secondary osteoarthritis. So, on to some of the research. One thing I did a few years ago was tack on to a very large epidemiological study that has been running for over 20 years in a suburb of London called Chingford. And you won't have heard of Chingford because Chingford is normal. It's regarded as the most normal part of London, whatever normal is for London. But this is a true general population cohort, followed very carefully for over 20 years. And what we did on 465 members of this normal population, aged between 63 and 85, was undertake a very detailed examination of their shoulders, both a clinical examination and also an imaging examination using high-definition ultrasound. And we separated the appearance of the rotator cuff on ultrasound into these groups. A normal tendon, an abnormal tendon at the insertion with the enthesis, and then partial tear, a full thickness tear less than 2.5 centimeters, and a full thickness tear greater than 2.5 centimeters. And what you will see in this next slide is the population prevalence in a normal population cohort of abnormal tendons, be they footprint abnormalities, the enthesial abnormality, right the way through to full thickness tears. So if you're 60 to 69, half the population have a tendon abnormality on imaging. If you're 70 to 79, it's 60%, and if you're 80 to 89, it's 70%, with an overall prevalence in this population of 59%. If you look at full thickness tears alone, then it's 14% in the 60-year-olds, 26% in the 70-year-olds, 29% in the 80-year-olds. So these problems get commoner as you get older. They will often occur in both shoulders, but by no means all. And so actually the bilateral presence of full thickness tears was only between 2 and 6% in this normal population cohort. And interestingly, there was no preponderance, particularly in the dominant rather than the non-dominant arm. So obviously the next question is, well, what's the relationship of these imaging abnormalities to symptoms? And so what we did was, again, in these groups, we compared the percentage within each ultrasound-defined group, so normal, abnormal, which included a footprint and a partial thickness tear, and then the smaller and the larger full thickness tears. We looked at the proportion who had no symptoms whatsoever, who were blue, and the proportions who had mild symptoms or up to severe symptoms. So this is just a binary. If you have a small thickness tear right the way down to a normal tear, essentially it's more likely you'll have no symptoms whatsoever. It's only when you get to the larger full thickness tears of greater than 2.5 centimeters, so essentially tears that extend beyond supraspinatus, that it's more likely you'll have symptoms than not. And that what we think is that this true population-based data helps us set our if you like, clinical interpretation of both patients presenting to us and imaging presenting to us in a context. So in the general population, minor abnormalities on imaging of the rotator cuff in this age group are more likely to be asymptomatic than symptomatic. So, what about treatment? And, you don't need me to repeat this, that there's generally speaking a lack of supporting evidence, and there's generally speaking a need for more well-designed trials if we're to improve our understanding of what we do. And I'm not going to go into lots of detail and background, but I'm going to present 3 trials that I've been involved in, 2 that have completed and reported, and 1 that is about to report, which I think might be of some interest to you. So the first trial, published just the end of last year, looked at whether or not platelet-rich plasma might be beneficial if given in addition to acromioplasty surgery. And we did this study not just to look at clinical outcomes, but to look at the effect on tissue of platelet-rich plasma. And we followed patients from 2 weeks all the way out to 2 years. And so this is a 2-year prospective randomized controlled trial. First thing to say is that the platelet-rich plasma we gave to the patients was not the same to every patient, because we assessed the platelet concentration and various other aspects and parameters. So it's a variable product. We used the centrifugation system, we used the best that we could get our hands on, but it's not a consistent product. And that seems to be through reasons that we can't control at the moment when we're generating this product. So that's a caveat. So the clinical study showed no difference at any stage between the 2 groups. So there's no additional value of giving PRP to not giving PRP. So it has no benefit, essentially. What we did at 12 weeks post-surgery, we took a core biopsy, true cut biopsy under ultrasound guidance in the outpatient clinic, and I'll show you the way I've developed the technique for doing that in a few minutes. But I think this is perhaps the most interesting aspect of this study, is that there was a significant difference between these 2 groups at 12 weeks. And that is that in the PRP group, there was a substantially reduced cell number, there was a substantially reduced vascularity, and there was a substantially increased rate of apoptosis in the group that had received PRP. So we don't know what this means in the longer term. It had no effect on this group clinically all the way out to 2 years, but we do feel that this requires some further thought and some further investigation. So we need to know more what the tissue effects of PRP are if we're going to use it as a therapeutic. So the next 2 studies involve surgical patients, and one study involves acromioplasty surgery and one study involves rotator cuff repair. What has been going on in the UK, like most other countries, is that there's been a dramatic increase in rates of surgery. The blue line is the rate of increase of acromioplasty surgery, and the red line is the increase in rotator cuff repair surgery. The green line is the increase in shoulder replacement surgery in England over a 10-year period. And what we know also is that there's uncertainty regarding the effectiveness of these treatments, to the extent we're not sure whether actually they're any more effective than conservative measures, exercise therapy, etc. And therefore there's a need for randomized trials. So I was commissioned by the UK government about 9 years ago now. It's amazing how long these things take, to do a randomized trial, multi-center, pragmatic trial in a real-world setting of open versus arthroscopic rotator cuff repair. And this was 256 repairs in 19 centers, and essentially what we found was absolutely no difference whatsoever between open or arthroscopic repair, whether we analyzed these cohorts by intention to treat or per protocol. So there is no difference. Not only that, not only between the two techniques, but also the variance of the techniques, be it single row, double row, whatever else. We don't seem to be making a difference to whether or not these patients get better or not. What we also did, in terms of the different techniques, what we also did was image all of these patients at 12 months and found a 40% failure to heal rate. So if you have a rotator cuff repair, and these were all sizes of tear, it was more likely that you'd have a re-rupture if you had a larger massive tear to a small and medium tear, but 30% of small and medium tears have failed to heal. Somewhere around 50% of large and massive tears fail to heal. Although there looks as though there's a difference between the two groups, arthroscopic failure rates at 46 and open at 38, this was not statistically significant. The other piece of information which I think is important to bear in mind, and it will come on to some of the stuff we've subsequently been doing, is that we used a patient-reported outcome score, the Oxford score, as our primary outcome measure, which 0 is the worst and 48 is the best. At baseline, the patients were around 25, 26. If you had surgery and the surgeon found an unrepairable tear, so essentially did nothing more than an acromioplasty, you got an increase in your score of somewhere around 10 points. So going from 26 to 37 or 25 to 35. So not having a repair at all resulted in the greatest reason for increase in outcome. If you retore, then you had a repair and it retore, that you were a little bit better. And if you had a healed repair, that was the best of all. So I suppose we're not surprised by the fact that the healed tears do well. It is surprising that the unrepairable tears do so well. And that, I think, raises the question, what's the mechanism of the treatment effect here? And that immediately swings me to the third trial that we've finished, and that was very much fed by a series of wonderful studies from Northern Europe and also some from the USA, where we compare surgery with placebo, with a sham surgery. And I got quite interested in this as a sort of an ethical issue a few years ago, and we undertook a systematic review of the role of placebo controls in surgery. This was published in the BMJ a couple of years ago and has now fed into a series of guidelines for the use of sham and placebo controls in surgery, led by the Nuffield Council of Bioethics. Essentially, none of these trials, there are only 53 ever reported, but none of them showed evidence of harm on the placebo side. So that is a big concern, I think, for a lot of people undertaking sham surgery studies, that there may be harm to the patients. In over half of the trials, there was no benefit of the real surgery over the placebo surgery. So essentially, the effect of the surgery is simply placebo. So we wonder, in the case of shoulder surgery, whether or not a component of treatment effect might be due to whatever is called the placebo or these other non-known treatment effects. So we began a sham surgery trial of acromioplasty surgery a few years ago. We have finished recruiting 300 patients. This trial is somewhat unusual in that we don't just have the active surgical arm, acromioplasty, and a sham surgery arm, arthroscopy only. We've also followed a third group with no treatment at all. So that's a natural history group, and that will allow us to determine the quantum of the placebo effect. And those results will be coming out later this year when we unblind the study. And we had relatively little crossover, which was nice. And I think one of the reasons for that was having developed a community of surgeons who had become used to randomizing patients. And I can't emphasize how important that is, that changing the world of evidence is not just a question of setting up a trial, but you've got to create a fertile ground in which to do the trial, which means you've got to train centers and train surgeons and train clinicians how to do a randomized trial, how to recruit and how to maintain that trial such that you get the sort of study completed. One aspect of interest for me for a while has been in the issue of pain, what causes pain. And we did a few years ago a cohort study looking at whether or not patients having acromioplasty had evidence of central sensitization, so had they got brain changes. And we found that. So we found imaging changes, and we also found changes on aspects of pain scoring, such as the pain detect score. And what was important from this study was that the greater the amount of central sensitization the patient had prior to shoulder surgery, the less well they did with the surgery. So central sensitization influenced the outcome of surgery. So in the placebo trial, the seesaw trial, in the patients recruited through Oxford, we've been doing fMRI brain studies. So we will also be able to see in that trial whether or not there is an effect on the brain of the sham surgery, as well as hopefully an effect of the real surgery. So if you invite me back in a couple of years, I'll tell you whether that's what's the result of that surgery. So that's the end of the second bit. So you've had the epidemiology, you've had the randomized trials. I'm going to talk now a bit about tissue studies and investigations of whether or not there is perhaps a role of inflammation. What is absolutely clear is that we're all struggling to work out in our clinical practice in treating our patients, how is it when we have a patient presenting with an injury, with a problem with a tendon, how do we encourage them to heal towards a normal tissue phenotype as opposed to a fibrotic or an abnormal tissue phenotype with the attendant issues of the structural competence of that tissue and persistence of symptoms. So one question I think is worth addressing, and I know it's always topical in this arena, is it true or not that there's inflammation in tendon? And I came at it with a completely sort of open mind. One of my students did do a little review looking at what does the published literature think, and we separated clinical reviews of tendinopathy and basic science reviews of tendinopathy. And this is tracking all the way back to the early 1980s. So we tracked every single review article we could find, and we've separated them into where they sit on the fence as to whether or not there's inflammation, whether they say there is inflammation in green, or whether they say no, there isn't inflammation in red. So these are the clinical reviews, and you can see the influence of this BMJ leader in 2002. So thereafter, there was an explosion of sort of, if you like, rejection of inflammation as a basis for tendon disease, or maybe it wasn't that BMJ after, maybe it was something else. Who knows? Anyway, association. And then the basic science reviews, which are quite different. So the basic science reviews are more uncertain. There's been lots of sort of toing and froing. Generally speaking, I think recently probably a bit more in favor of inflammation than not. Anyway, that's the background. So one of the things we've been doing in Oxford for many years is trying to use human tissue to determine disease, and an element of that is the Kennedy and describing TNF as a target for rheumatoid, and the production of monoclonal antibodies to TNF. That wouldn't have come without a series of studies understanding the disease in humans. And I think this is really important aspect of progress, that we get to the heart of mechanism of disease, because only by determining mechanism of disease can we genuinely come up with new therapeutic targets other than perhaps by serendipity or chance. So an aspect of this obviously is how do we get access to tissue that we can use in laboratory studies. And like a number of other people, Michael obviously included, access to tissue using guided biopsies that we can do in the outpatient setting repeatedly under ultrasound guidance was a really attractive concept to me, and we've developed in the rotator cuff a means by which we can do this not just once but on a number of occasions in patient cohorts. We've developed a series of cohorts where we biopsy them at a baseline presentation, pre-treatment, and then we will examine them and follow them, and right up the way out to 5 years now, we've been taking biopsies of the rotator cuff in patients. We have a group of about 500 patients in whom we've done this, and we've looked at different kinds of treatments, pre and post. So cortisone treatment, acromioplasty, rotator cuff repair surgery, and have been able to subdivide the follow-up cohorts into those people who become symptom-free and those people in whom the symptoms persist in some manifestation. And the research question we've asked is, what's the difference, partly between baseline and follow-up, although quite rightly people have questioned whether or not the biopsy itself might be creating a tissue effect, and I don't know the answer to that. But more importantly, what's the difference between those that get better and those that don't get better? And can we, by looking at that, understand aspects of disease mechanism? So what we find, looking across the range of disease in the rotator cuff, not surprisingly, is as you go through the disease stages, you tend to get a more disorganized matrix, you tend to get more abnormal cells, you tend to get increased amounts of apoptosis. So much of the early observational work we did was not surprising and is mirrored and matched by research groups from around the world. The question that we did want to get to was, is it possible, is it plausible that there is an inflammatory process either at the initiation or at some later stage in the disease process? And what might the cell types be that we should be seeing if inflammation was present? And this is the classic picture of inflammation where there's initiation with pro-inflammatory mediators, and then there's resolution with pro-resolving mediators, and you see phased appearance and disappearance of neutrophils, then monocytes and macrophages, and in the background as controlling cells, the very important role of T cells and mast cells. It does appear from studies around the world that there is some evidence, particularly in the early stage of disease, that there are inflammatory cells present within tendon. And I think that body of evidence is growing quite significantly now. So precisely what the role of this inflammation is and how it fits in with other provoking and promoting factors we have yet to determine. But in terms of the base question, is there inflammation or not? My personal view is yes, there is. And that immune cells, in some way, I know this is a sports conference, so I thought I'd put players onto the pitch. Well, you've got some immune cells playing in your sport here, whether you like it or not. Now, whether they're the goalie or a defender or an attacker, I don't know yet, but they're on the pitch, and we've got to take them into account. And in what way they're doing this, I think it's going to be some interesting science going forward. What's the role of the neutrophil? I suspect the neutrophil has a relatively small, very short-lived, if anything at all, part. But the regulatory T cell, I think, will, as does the macrophage. And the macrophage is interesting as a cell. It's classically described in two phenotypes, the M1, pro-inflammatory, and the M2, tissue repairing. That's a very crude separation, and I'll just take you a bit further through that in a few minutes. But generally speaking, this is a very busy slide, but I just want to show you that this is a real game on a real pitch, and there are many substitutes coming on and off the pitch at different times. And the team that is there at the end of the game is not the team that's there at the beginning of the game. And in particular, the macrophage comes and goes, and its change in type and its polarization are critically important to tissue going from some sort of damage to resolution. And if you get your substitutions wrong as the manager, then you'll end up with a bad result. Just to illustrate to you the importance of the macrophage. So and also to introduce this issue of age, that as we get older, we're less able to play the sport, so to repair tissue. If you take a neonatal heart and you damage it, it will recover almost to normality. If you take a neonatal heart and you damage it and remove the macrophages, it will scar up. If you take an adult heart and damage it, it will scar up. So what we're seeing is the importance of age and the importance of certain cell types in the ability of tissue to repair. So a quick early piece of work that we did on tissue acquired from some of our trials was to look at whether or not there was a difference in simple cell number between the patients who became pain-free and the patients who were persistently painful. And there was. So there were, essentially, if you've got persistent pain, you have a greater number of these active cells, monocytes and macrophages. Another question that we asked was whether or not there might be a relationship between these inflammatory processes and nociceptive signaling. And we looked at a variety of different pathways, but the one that came out as being most interesting was the glutamate pathway, both the glutamate as a signaling agent and also its receptor here, NMDA1. So what we found here was that the greater the pain, the greater the extent of the disease, the more glutamate and the more glutamate receptor were present in our tissues. So what we then wanted to do was further dissect this issue of both activation and resolution of human disease. And this work was led by Steph Dakin, who's a postdoc in my group, and recently published in Science Translational Medicine. So this is looking in more detail at this issue of what are the cells doing. And what's very clear is that you do get an attempt at resolution in early disease. So tendon is trying to heal itself, and we get quite significant production of pro-resolving proteins in early stage disease. What we also see is a change in the polarization or the type of macrophage. It's now possible to be much more specific about and it's much more complicated than just M1 and M2 macrophages. There are a number of different markers that we can use to look at these. But essentially, if you get your macrophage polarization wrong, then you will go to fibrosis. If you get it right, then you go towards minimal scarring. So these cells are important. Not only did we look at cell number, we also looked at gene expression. And what was interesting here was that in tendons that become pain-free, you have a much greater expression of pro-resolving genes. So genes that are trying to help tissue repair as opposed to not repair. So what we're seeing is in the patients who get better, a better orchestration of their cell types, particularly their macrophages, and also that the cells are producing more of the kinds of proteins that we want to see in a resolving situation. So this again is evidence, in my view, that inflammation is a key component and a key part in both the initiation and the end result of a tendon injury. This final piece, I think, is perhaps even more important than anything else, and that is that it isn't just about the inflammatory cells. It's also about the response of the resident population, the so-called stroma. And what we have found and are pursuing much further is the tendency of the stromal population to change its phenotype. So in a tendon that becomes injured, it's not just about these controlling, relatively small number of controlling cells, the macrophages. It's the fact that the resident tenocytes change their polarization. They change themselves. They become much more susceptible to being triggered off by a pro-inflammatory cytokine or a pro-resolving cytokine. So treating abnormal tendinopathic disease isn't just about the inflammatory cells and addressing those, perhaps by giving a dose of cortisone or something like that. We've got to change the whole resident population once the tendinopathy gets established. So just to try and bring this all together, what we're thinking now is that there are these different forms of inflammation, what you might call the good, the bad, and the ugly. And good inflammation is when it comes and goes and you get resolution. Bad inflammation is when it comes but it doesn't go. And it might not go in two manifestations. One is a manifestation which is above a triggering threshold for pain, the orange line, or below a triggering threshold for pain, which is the blue line. So in some people, you get a lingering, smoldering inflammation, which is there even though the patient hasn't got symptoms. In some, you clearly have the opposite. It is much more significant and you get pain. There's a further kind of inflammation, we believe, which is a kind of inflammation which appears but never becomes painful, creates a change in the tissue, and that's the group that we think end up with spontaneous ruptures having no significant prodromal symptoms. So what triggers inflammation? And this is clearly incredibly important. And this is an area which I think as we begin to understand the role of inflammation better, we might be able to understand the triggers. And they're clearly multiple. But in the context of the shoulder, the important thing to consider is that this is a particular part of the tendon where it gets the problem. It's the enthesis. It's the biological interface between soft and hard tissue. And I know the Achilles is slightly different, but for me in studying the rotator cuff, this has been an important consideration, that we're dealing with a particular part of the human body which is subject to very considerable mechanical stresses and which has a very particular cellular phenotype to control that interface between hard and soft tissue. It's very prone to injury. And arising from other areas of science, there's some very interesting new insights into immunological conditions which occur at the enthesis, such as ankylosing spondylitis, where it's now very clear that there are particular immune cells involved in the onset and progression of ANKSPOND, particularly the IL-17 and IL-23 pathways, and that those pathways are intimately connected with triggering from mucosal barriers. So if you have some kind of event, inflammatory event going on in your gut, you create a shower of these active cells. These active cells are very likely, particularly in immune predisposed patients, such as HLA-B27 patients, to create an enthesitis. Now, it is entirely plausible, in my view, that we might have some sort of triggering event from these kinds of pathways in patients with more general tendinopathies, particularly at the enthesis. And that might be an explanation for some of the things we see in ultrasound, which is these abnormal interfaces between tendon and bone. So what should we be doing? Well, I think we need to be really trying to think out of the box now, going forward the next 10 years. Not recycling some of the stuff we've been doing for years and years, which if it was going to work, in my view, should have done by now. So how is it that we can try and find genuinely new targets, be they pro-resolving from pharma, aspects to do perhaps with this hypothesis of the microbiome, so nutritional kinds of strategies, and how is it that we can harness biophysical cues to change the stromal population into a less inflammatory or less predisposed to inflammation? Because what is absolutely clear is that the stroma, the tenocyte population, is as sensitive to biomechanical cues as it is to biochemical cues. And that is a segue into the final bit of my talk, which is another aspect of what we're doing in my lab, which is to look at tissue engineering solutions to rotator cuff repair and to use these technologies that have emerged relatively recently of being able to create very small-scale fibers and materials. And Thomson Reuters, in their review of the world of material sciences a few years ago, picked up 3 materials as being probably likely to be most transformative in the world of science and the world of human health. One is graphene, which I'm sure you've all heard of this ability to create single-cell structures through with carbon. The other is metal organic frameworks, the ability to capture an organic within a metal framework and therefore have a material with the functionality of both an organic and a metal. And the final one is the ability to create very, very fine fibers using a technique called electrospinning. And this is particularly of relevance to tissue engineering. And electrospinning essentially draws a polymer from a nozzle onto a collecting plate using an electric charge. And that fiber is submicron. So essentially, you can create fibers the size of cells. And what happens is that cells exquisitely respond to that new set of cues and signals. So if you grow a cell on a very soft electrospun fiber, this is a mesenchymal stem cell, it will differentiate towards a brain lineage, neurogenic lineage. If you grow a stem cell on a relatively stiff electrospun fiber, it will grow towards a bone lineage. So you can direct the differentiation of stem cells without chemicals, without drugs, simply using biophysical cues. And you can see here some work we've been doing in the lab where growing, these are tenocytes from patients with rotator cuff tears. If you grow a tenocyte on a conventional fiber, it changes relatively little in terms of its ability to differentiate and proliferate. If you grow a tenocyte on a nanofiber scaffold, within 24 hours it's changed its shape, and within 12 weeks, those tenocytes have proliferated and produced much more type 1 collagen, and the mechanism of that is really fascinating. It's probably an epigenetic mechanism where the signals from the cell surface create a demethylation and deacetylation of chromatin, and that switches on genes that have been senescent for a long period of time. I think this is really exciting in terms of the potential for surgery, and this, I'll just show you some live. I'm very excited by this because we only got this a few weeks ago. So this is some live cell imaging. So this is a tenocyte from an 80-year-old patient with a massive unrepairable rotator cuff tear. Normally when you put these cells onto scaffolds, they just sit there, they do nothing. But what we've done here is put these tenocytes, there are two of them, one on the left, one on the right, onto a scaffold that's running from top left to bottom right. And you can see the size of the fibers. They're really tiny. They're about the size of collagen fibrils. And so what happens as you grow the cells on these fibers is they grab onto the fibers and they grow out along the fibers. The cell on the left, you'll see, grabs and then loses its grip, but then reattaches and grows along the fiber. So I'll just run this movie for you. So this is the cell change. This is hours. This is all within 12 hours. You can see how the cells are feeling the fibers, changing their shape, then they're migrating along the fibers. So this gives us the potential to create scaffolds which change endogenous cell behavior. So the challenge is, how do we get those into a product that we can put into patients? So what we've been developing in the lab is a laminated structure, combination of a woven scaffold with an electrospun scaffold. That gives us something that we can surgically implant. And what we intend to do is to put these scaffolds over the top of rotator cuff repairs, but we could equally use them for other tendon repairs, or indeed with modifications for fracture repair or hernias and things like that. And we are at the stage now with these scaffolds that we're just in this next 12 months moving into first-in-man trials. And so, that's obviously exciting, and we hope to be able to report back on that again in a year or two's time. So I'm coming to the end, you'll be pleased to know. I just want to sort of just try and encapsulate, I suppose, the way I've been trying to do things, and that's, as a clinical scientist, to address the clinical problem, which is we don't know how to better treat rotator cuff problems, particularly for me, the surgical management, but also the non-surgical management. I think if we're going to get better at this, it's crucial that we understand why. Why is the disease there? Where are the targets? Let's try and then develop some solutions and take that through into properly designed human trials. An awful lot of the treatments we've currently got don't have proper trials to back them up, and I think that there's a need for that. I'd just like to thank my funders, the Wellcome Trust, MRC, Arthritis UK, and the National Institute for Health, and this wonderful group of scientists that I work with who have done the epidemiology work, the clinical trials, and do the basic work in the lab. So I hope that's been of some interest. Thank you very much for your attention.
Thanks very much, Andrew. Just a few comments, questions are possible. We have some time, but let me go back to the beginning that you talked about the rotator cuff rupture with increasing frequency with aging, and then the constant discussion of that's one type of tendon, and then you have the Achilles tendon, you have the patellar tendon. And when we talk about increasing tendon rupture with aging, we very often talk about the shoulder spontaneous ruptures, but we don't see it so much in some of the other tendons. So what do you think is the difference between, why is it happening? I mean, you've tried to give some explanation for why it's happening there, but why don't we see more spontaneous ruptures in older people of Achilles tendon and patella. I mean, it's quite frequent there.
I think the shoulder is which I tried to introduce, I think the shoulder is a particular biomechanical place and space, and I think these tendons of the rotator cuff probably are as yet under-evolved. So we're not long enough from having been quadruped to being bipedal. So I think there are particular aspects of the rotator cuff which don't translate into other tendons, be it the patella or the Achilles. But there may be aspects of what we can learn from the rotator cuff which do translate in terms of underlying mechanism. The propensity to rupture is clearly different between the rotator cuff and other tendons. But we are doing some work, as you know, Mike, on the Achilles now, looking at these inflammatory processes, and what we're finding is similar findings at that cellular level between the two. But I've got to do more work there.
I was just thinking of the loading part of it, and then was it Per? Yeah.
Per Hølmik, Copenhagen. Thank you very much for a fantastic lecture. You're getting really around the whole subject, and it's been very amazing to listen to. I'm quite interested. I'm a surgeon, so I'm quite interested in the surgical studies as well. And last year we were discussing the sham surgeries that were done on the meniscus, and we had some quite vigorous discussions here, up and down and back and forth, and also later on in the bar, because there was...
I hope you didn't get a sham drink.
No. I can assure you, you won't get that tonight either. No, but your sham study, is it really a sham study? Because you are, as far as I understand from reading the protocol as well, and I know we've communicated a little bit about this, you are cleaning out the bursa to take an overview of the rotator cuff up there, to take a look at the ligament and the bony stuff. So, but you're not touching that. I understand that. But you're touching the bursa and you're taking out the bursa.
No, we're not taking out the bursa. So there's no...
How can you see in the subacromial space without...
So there's no tissue removal.
Sorry?
There's no tissue removal.
No tissue removal at all?
At all. You're quite right. So to question this word sham and the word placebo, and actually we deliberately in the trial don't use the word sham. I think sham should be reserved for the arm of a trial where you make a skin incision only, and there's no component of the surgery. What we prefer to use is the word placebo, and the placebo arm of the trial is the arm of the trial where the critical element has been removed. So in acromioplasty surgery, that's the removal of the spur of bone, the release of the coracomial ligament, and the removal of the bursa. And in the placebo arm of the seesaw trial, no tissue is removed whatsoever. So if you can't see in the bursa, you say, I couldn't see anything. So you remove no tissue.
Okay, so why are you entering the subacromial space?
Because in some patients, and indeed actually over half the patients, a view was obtained that allowed the surgeon to make some judgment from within the bursa. But none of these trials are perfect, and they aren't perfect in a number of different ways. But in my view, where no harm has been caused by the placebo arm of this trial, for conditions like shoulder pain or knee pain, where the outcome of the surgery is purely objective, and where it's plausible that there is a placebo component to the treatment effect, I think there's a case and a place for these trials to be done. Because if the only treatment effect is a placebo effect, and 1 in 1,000 patients gets an infection, then that's probably something we shouldn't be doing. So the question for acromioplasty surgery is, what is the magnitude of the placebo effect?
Other questions? Yep, there's one up here. Right here.
Hi. So I have a question as a physiotherapist. At what point would you recommend a patient to take a corticosteroid injection than using, the normal way of therapeutic, like movements and all that? Because I know inducing movements can also increase more inflammation, and that will reduce the rehabilitation.
So, my view on glucocorticoid injections for the rotator cuff is that the effects are short-term. And my view is also that there is potentially a long-term damaging effect to the mechanical properties of the tendon. So, in patients where there is already significant structural abnormality, unrepairable tears, for example, I have no concern about giving cortisone for the potential beneficial effect on pain. In a younger patient, I'm very cautious about the use of glucocorticoid, and I would avoid it if I possibly can.
At what age would you recommend more?
Well, as I get older, young gets... I think, I don't know, I don't think there is an absolute cutoff. It's to do with the patient and their biology and everything. But certainly patients 65 and older, I'm not so worried. But patients 45 and younger, I'm very worried about use of glucocorticoids.
Thank you very much.
So Andy, the thing you showed about the platelet-rich plasma, the experiment there where that was added, and you basically, I guess, follow a lot of other studies, at least from the clinical output, that there's no additional treatment there. But you spoke very shortly on you had some other findings where there was more apoptosis, there were less cells, but the clinical outcome was still the same. I was just wondering, because later in your presentation you talked about the difference about a painful tendon and a non-painful tendon, where the painful tendon typically had more cells. So maybe, I mean, can you speculate a little bit? You almost alluded to that there was, I mean, how can it go well when you have apoptosis or less cells, or is it good that...
I don't know. I mean, it's an observation. To me, the hypothesis was, is there a clinical effect of PRP in addition to acromioplasty, and is there a tissue effect? And we found no difference in clinical outcome. We were powered really for clinical outcome. So this wasn't a huge study, it was 40 patients. But there was no difference in clinical outcome. We did find a difference in tissue outcome. I don't know what that means. It needs more investigation.
Okay, I think we will thank... Oh, there's one more? Yeah. Should be on. There's even one more after that. 2 more questions.
Thank you. If you just take us back to the sham surgery, is it just strictly laparoscopic interventions? So it's not open surgery, is it? The sham surgery, you said you go in and you make a skin incision and you come out. Are we talking strictly about laparoscopic intervention and not open surgery? Sham surgery, I'm talking.
I'm not sure.
Right, sham surgery, you defined it as going in, making a skin incision and coming out and not doing anything.
So the Moseley trial was, in my view, what I would call sham surgery. The trials where you look inside, and therefore there is diagnostic value for the patient.
And that's just keyhole.
But you don't remove any meniscus from the knee, or you don't remove the spur on the acromion. We would define that as placebo surgery.
Yeah, but it's not an open surgery, it's just a keyhole surgery, isn't it? Now, the outcome of sham surgery, as I kind of could work it out, is it changes the central sensitization, so patients' perception...
But we don't know that.
I mean, we're assuming that, aren't we?
Well, I'm not assuming anything.
Right. So my question
I'm investigating it.
Yeah, my question is, if we prove that point, and it's all about central sensitization...
Well, what's intriguing, I mean, it is an absolutely fascinating area of science, is what is the physiology of what we call placebo. And it's wonderful science, but it's not going to be as straightforward as simply changing central sensitization.
Yeah, I appreciate that, but my view about it? I know it's not kind of, black and white, and there's always a gray area in that. But if we assume we conclude that it changes the sensitization and patient satisfaction, being intervened, is there a scope for open sham surgery in the future? Like, you open everything and close it down.
Well, there have been some very interesting open surgical trials with a placebo or sham component. The famous one was from the 1950s, where they did a thoracotomy. And this was in the days when it was treatment for angina was to tie off the internal mammary artery. Sure. So they did, half the patients had a thoracotomy and nothing, and half the patients had the internal mammary ligation, and they found no difference between the groups. Okay. In my view, I don't think that would get past the ethic committees these days. I think there's a different trial designed to address that question. I think that's a step too far. So I think you must be sure that the chance of you doing harm in the placebo arm is minimal.
Okay, thank you.
To justify a sham surgery trial. Okay. And you must also, there mustn't be an alternative. So you've got to be really uncertain as to whether or not this treatment is the right thing to be doing.
Okay, last question.
Yes, Klaus Bach. I'm an orthopedic surgeon. I just have a question concerning the corticosteroid. I agree that we should not use it too much. What is your opinion? Because I use it in younger sometimes, because if they have pain, if they have inflammation, then they have a chance that they can better go to the physiotherapist making the exercises. So what do you think, or is there any science showing the tremendous effects of corticosteroid versus inflammation? Because in my opinion, inflammation and pain also has some damaging effects.
No, I think you're completely right. It's we're in the horns of a dilemma, aren't we? I mean, the evidence of detrimental mechanical effects are there, but are very weak. So we put a systematic review out on the effects of cortisone last year, actually, in the British Journal of Sports Medicine. It is there, but it's very weak. So it's balancing that concern, perhaps alongside quite significant cellular in vitro work showing potentially damaging effects of cortisone. You put those two things against the fact that if you give a cortisone injection to your patient in pain, they will probably have improved pain, and you can therefore rehabilitate them and get them going. So it's that balance, isn't it? And I guess you have to do it on a case-by-case basis, as we all do. How bad is the pain in this person? What are their expectations and demands? Explain to them the risk, and sometimes you'll do it because you see no alternative. So I'm certainly not stood here saying never give cortisone to younger people, but I am stood here saying it worries me to give cortisone to younger people.
Okay, thank you very much once again. We'll thank Andy Carr for this.